Hi, everyone. My name is Irtaza Asar, and welcome to another episode of The Learning Curve, where we spotlight the rising voices in medical education and dive deep into the ideas that reshape how we teach, lead, and learn in healthcare. Today's episode is all about those critical moments, the ones where chaos reigns, time is short, and the room is waiting for someone to take the lead. Because when the heart stops, the blood pressure drops, or when the trauma bay doors swing open, it's not really just about the clinical know-how, it's also about leadership. So what separates a chaotic leadership from a coordinated life-saving effort? How do you actually lead when seconds matter? Joining me today is Dr. Vicki Zhou, who is an assistant program director at the University of Vermont, and she has a deep expertise in resuscitation leadership. Together, we're going to unpack what it means to truly lead a resuscitation, and we're going to explore the skills that define great resuscitation leadership. So, without further ado, let's get started with the conversation. Vicki, thank you so much for joining me today.
Thanks, Rich. So I'm really excited to be here. Thanks for having me.
Absolutely. So every single one of the guests that I've had on has always had like this hidden skill that I feel like we have to dive into before we dive into the topic. And Vicki told me about this incredible thing that she does. And Vicki, can you share with the audience about something special that you bake and just teach me a little bit about that?
Yeah, thanks for asking. One of my favorite things to do before a night shift, and I'm a nocturnist, so I work all nights, is to bring something in to share with the team. And my favorite thing to make is jam bars. Jam bars are so delicious no matter what you put in them, which is the best part. So I'll do apple butter, I'll do strawberry jam. I actually just got a gift from a family friend who has their own farm and they grow their own strawberries and they made all this amazing jam. And I'm really excited to make some bars for my next night shift to bring in. So I wouldn't quite call it a superpower, but it's something I really enjoy doing, and it makes every shift a little bit better when we have a little treat to share at 3 a.m.
That is awesome. And I think that's actually a really great segue into resuscitation leadership. So, Vicki, so let's start the conversation about resuscitation leadership. What is resuscitation leadership?
That's a great question. So we all know that in the emergency department, we deal with high stakes, high pressure situations all the time. And we have an entire team to lead as residents, as attendings, as fellows during these really critical moments. And we don't spend a lot of time in our medical education as trainees learning about skills specific to this. It differs really from general leadership skills because we're really making split-second decision making under a lot of uncertainty and with the high stakes of our patients' lives at our hands. General leadership is really a coordination of multidisciplinary teams and being able to communicate under pressure, but resuscitation leadership is at a whole different level because of the situations we deal with in the emergency room. So I often think about when I describe this to people, what exactly a resuscitation leader is. And we often think of emergency medicine physicians sort of standing at the head of the bed, barking out orders. But it's really important to note that being a resuscitation leader is related to leading a team, and that should really be the focus. Some of the common situations that I think about and that you guys probably think about as ER doctors is being able to lead a trauma bay that's full of multiple sick patients. Running a cardiac arrest or a code is a very common situation. And then leading, a sick sepsis resuscitation. Those are all really great examples when we do this every shift.
Awesome. And I think that's a great overview of what resuscitation leadership is. I think this has become part of that hidden curriculum. And I've also found that it tends to be a little bit of a blind spot when it comes to educating residents about what resuscitation leadership is. So, Vicki, let me ask you a follow-up question to this. What do you think are the core skills of an effective resuscitation leader?
So, most importantly, and I think this is part of our job as emergency physicians, but even more important as resuscitation leaders, is communication and specifically clear, decisive communication. We talk a lot about closed loop communication. So, making sure that you're, as a leader, that those we might call followers in a resuscitation know what we're talking about and communicate back those decisions and those communications back to us. And I often use a model when I'm being a resuscitation leader of what we call SBAR communication, which is situation, background, assessment, and recommendation. So your situation is what is going on with the patient, your background, what is the clinical context of the resuscitation that you're leading, an assessment, what do I think the problem is? And finally, a recommendation, what would I do to correct it? And this can be a really good model to utilize when you're communicating with your team and sharing your mental model. So that's sort of the next important core skill of an effective resuscitation leader. So a shared mental model is basically being able to disseminate your plan to your team. So really utilizing all those skills that I just talked about with the S bar to regain the whole team's attention and to really be able to verbally communicate the important details of what's going on so that everybody in the room understands. I think we've all been in resusces where it's a really complicated patient. We don't all have the same information. We haven't all gotten to review the patient's chart and their medical history. And oftentimes, when it's really busy, we don't know all of the different things that our team members are doing. So sharing that mental model really, like I said, gets everybody on the same page and can really do so in just a number of minutes. It doesn't take a lot of time. The third important skill that I really want to mention is this idea of mutual support. This comes with the idea of psychological safety. I just mentioned how there's a lot of different team members in the room, but by sharing that mental model, everybody sort of gets a moment to share their opinions about what's going on.
And I think that's actually a really great point. And I wanted to kind of segue back to your SBAR framework. I think that's something that I've talked to a lot of my residents about, where some of the things that they've told me specifically is that, hey, something that I really struggle with is running codes on the floor when I'm dealing with staff members that haven't really taken care of critical patients. So I walk in the room and it's almost like this information overload, and they keep telling me about 8 different things that are up with the patient when in reality, I just want to know select key pieces of information. So that's something that I've gotten in the habit of talking to residents about. Hey, listen, codes in the emergency department are a lot easier than floor codes. When you go up there, you're going to be bombarded with 9 different things. From your standpoint, really go in there, use this framework to basically narrow down the things that you really want to know, and then focus on stabilizing the patient to the best of your ability with the resources that you have. And that framework can really help you regardless of the staff members that you're working with, regardless of the situation you find yourself with. And I think that framework is really, really valuable. One of the other things that I wanted to pick your brain about is cognitive offloading. Where do you think that plays a role in resuscitation leadership?
So cognitive offloading is something that you should always have in mind because we all know that feeling of different tasks running through your head in different directions and not knowing what order to put them in, 1 through 10, 1 through 20. There's so many things that we have to do. And especially as a resuscitation leader, we sort of expect ourselves to do everything. But delegating is incredibly important. And I think that I feel very lucky to work at a tertiary care emergency department where I have many capable individuals who all have many important thoughts running through their brain. And being able to effectively delegate tasks to those capable individuals is really important. I think at the same time, you have to recognize the strengths and the weaknesses of the different team members that you have, and that you may be working in a less resourced emergency department with people who really might not have the level of skills that you might expect from your team, and being able to effectively delegate the right tasks to different people based on their skill levels.
Absolutely. I think that's something really key that I would take away and really talk to a young learner about that. Hey, listen, let's say you have a cardiac arrest. Let somebody know when you want pulse checks. Let somebody know when you want the next dose of epi, and let them keep track of that time. But also make sure that there's somebody that's done ACLS before so they can also be equipped to respond to you when needed. And that's one less thing that you can worry about. And instead, you can focus on, let's say, the H's and the T's and all the other things that really go into leading the resuscitation. So I think that's actually a really fantastic point. Now, one other thing that I've really found that's common among a lot of great resuscitation leaders is the debrief afterwards. Can you talk to me about debriefing and reflection?
So debriefing is an incredibly important part for after codes is when we think about it most often. But really, any situation where you have an ill patient that you're dealing with a lot of team members who are involved. And I like to use this idea of a global assessment where we do a reality check. We basically question underlying assumptions, talk about the chosen path for the resuscitation, and then reflect on what different members contributed and what we think went well and what we would think could be changed for the next time. And really, this is an important piece for quality improvement, but also I think it's really important for the well-being of the team afterwards to have that space to be able to talk about not only the nitty-gritty of the medical parts of things, but what we might describe as softer skills as far as communication and also any feelings that might be had after a difficult case.
Yeah, absolutely. This is something that I've been trying to get better at myself, especially having some recently challenging cases, from recent trauma cases to pediatric cases. I think taking that few 5, 10, 15 minutes, gathering the entire team in a separate part of the emergency department, having them separated from that initial event and talking to them about things that went right, things that went wrong, how's everybody's emotional state. I think that processing can really help in that moment, but also for the next resuscitation that comes up. And I think that only helps to build that trust moving forward. So, Vicki, my follow-up question to you is this. Can you give me some real life examples of resuscitation leadership in action?
Yeah. So I work at two places here in Vermont. I actually work at one site in New York State, which is across Lake Champlain. And that is more of a community hospital that doesn't have all of our in-house specialists at night. One of the cases that I think about often is from when I first started as an attending, and it was specifically a pediatric case. And I think for a lot of people, pediatric cases and especially resuscitations are the hardest ones and the things that we reflect on as challenges in our career. So it was a case of a patient who unfortunately had a accidental fall at a school dance, and he was 8 years old. And we won't go into the medical details, but there were a lot of moving parts because we didn't have neurosurgery. We didn't have a specialist who was well versed in how to manage a pretty large epidural hematoma. And we had a lot of people in the room that were all trying to do their different tasks. We had a pharmacist, we had a general surgeon, we had the team. And it was really challenging because we were all outside of our comfort zone and we all weren't entirely clear of the different skill levels of the different providers in the room and comfort in the situation. And I think ultimately the patient got transferred to a higher level of care and got the care that he needed. But really, the hardest part was being in the room and not knowing different people's roles and skill levels, like I mentioned. And reflecting on that for what we might describe as a well-led resuscitation, we did have a small moment before the pre-hospital team came in, sort of knowing what the case would be. And I think if we had gone and used role delegation and also used better closed loop communication and that SBAR communication tool that I talked about, I think that we'd have all left the resuscitation feeling a little bit more comfortable. This is a really high stakes trauma resuscitation in a resource limited setting. So there's always going to be challenges, but I often reflect on how being an effective resuscitation leader as the ED attending who's ultimately in charge might have changed how we all felt after the situation.
And I think that's a really fantastic example of resuscitation leadership in action. And you're right. I think pediatric resuscitations tend to have another gravity that I think is very hard to take into account, especially early on. Funnily enough, I was actually giving a lecture today on pediatric emergencies. And before I started the lecture, I asked my residents, hey, let's imagine this. You're working as an attending, it's your first day on shift, and you have a cardiac arrest. I had them close their eyes. I asked them this question. And then I had them open their eyes and I said, hey, what's your stress level? And a lot of the residents were like 3, 4, because we see it commonly. We have that stress inoculation that you talked about earlier. And I said, okay, let me have you close your eyes back again. There was one little detail that I forgot to mention. It's an 8-month-old pediatric cardiac arrest that's coming in. I had them open their eyes and I said, hey, what's your stress level on a scale of 1 to 10? I heard 14. And it was one of those moments where I was like, yeah, this is definitely extremely stressful, but you're going to be, odds are, if you're at a single provider site, you're going to be the only one that's going to be able to lead this resuscitation. So you need to get your team in order. You have to make sure that you have all the equipment ready. You have to make sure that you have the algorithm in the back of your mind. You have to make sure that you're going through the H's and T's. You have to make sure that your team members feel comfortable and are able to carry out this resuscitation to a really, really high level. So I think that's a great example. And I'm sure that you guys did everything that you could to essentially provide the best care possible for that patient. So I think that's a great, great analogy. Are there any other examples that you can think of strong resuscitation leadership?
So I often think about where resuscitation leadership came from. And really, there's a lot of other situations outside of medicine that really are high stakes scenarios and what I would call organizations that are like high reliability organizations. So basically, stressful, high stakes situations where you need every step to potentially go right to get a good outcome. So I don't have another specific emergency department example to share, but I think we have a lot to learn from like the military, aviation, even our EMS and pre-hospital care folk that we interact with it on a daily basis. They really lead these difficult situations and their high stakes situations as well.
Yeah, and I think the aviation one is actually a really great example that I think we were talking about it before, but I really want to kind of dive into is you talked about something called a high reliability organization. Can you elaborate a little bit about that and how that ties into the aviation industry?
Yeah, absolutely. A high reliability organization, basically, like I said, they have to work together in these high acuity situations, and they really have a high potential for error because there's so many moving parts, but they're still always able to really deliver the same effective care or same effective outcome. And similar to the emergency department, they really rely on good communication and teamwork and making sure that everybody knows their roles and is able to do them correctly and communicate that back. And it's really what we strive for in medicine ultimately, and especially in the emergency department of all places.
That's actually a really great framework that we can always look back at to reference because, again, like you said, these are high stakes situations. The margin for error is very, very small. And just like in the emergency department, the aviation industry is expected to perform at an extremely high level. So that's actually a really fantastic example. So now that we've got all these examples on the table, what can we do to essentially get better at resuscitation leadership?
So I think there are a lot of ways to practice these skills. The most obvious one would be in the emergency department, but really we should be training our learners ahead of time. And I think simulation is becoming an increasingly important part of residency, and especially with the new ACGME changes that may be coming. I think we think a lot about how we can utilize simulation to prepare our learners before they are put in these high stakes scenario in the emergency department. So high fidelity sim labs to provide essentially this feeling of real world practice should be integrated into everybody's weekly didactics, and really being able to practice these resuscitation leadership skills for situations that we don't deal with very often, for instance, pediatric codes or traumas, like we've been talking about. It really provides a safe space where learners can feel that little bit of pressure, but not with the pressure of poor outcome essentially happening. I really like the idea of practicing sim cases where you're working in resource limited settings, because the reality is that you oftentimes won't have XYZ nurse,
Yeah.
tech, respiratory therapist that knows every single thing. And you'll really have to do a lot of those things on your own, or very specifically tell your team members what to do.
Absolutely. And that's something that I've really been trying to work on as an educator myself is trying to create some of these moments for residents to try to help them get more comfortable or as comfortable as can be for these kind of high stakes situations when they come. Because again, the only way that you can really put people in these kinds of positions is if you try to do these high stakes simulations that can replicate the stress that comes with these high stake moments. So we talked about high fidelity sims. Is there anything from a role playing standpoint that can also help from a resuscitation leadership skill development?
Yeah, I think one of the role playing things that you can do at your program is to actually get individuals, actually nurses, techs, other people that you work with daily in the emergency department to be involved in these trainings. You can definitely do in situ sims, which basically is a simulation in the physical space of the emergency department or whatever clinical space you work in. And I think that really puts an emphasis on actual real life roles and makes the simulation even more realistic, and can also help you become more familiar with your footprint, with your space, which is so important in resuscitation because you really don't want to be thinking about all those logistics ahead of time. You really want to know your space and your resources so that you don't have to think about them when you're feeling very stressed. But that Inside 2Sim is a really great way to role play and get other types of individuals, team members involved.
Awesome. We do something similar at my site right now with our postpartum hemorrhage sim cases. We actually bring in our postpartum sim cart and we try to go through that with multiple different staff members at all different levels to make sure that we're all aware of specifically what's in the cart, what needs to be given at what time. And I think that's one way we've tried to replicate that. What else can we do from your standpoint, specifically with regards to stress inoculation and mental rehearsal that can also help learners?
That's a great question. So we've talked about stress inoculation a lot, and I think residency in itself is a long-term 3 or 4 year stress inoculation to make you that calm attending who just stands there during a difficult resuscitation and isn't breaking a sweat. I think the role of visualization and preparation is really important, and having your learners think about these situations from a early point in their training is really important. And like I said, I think simulation is something that should be integrated longitudinally in a residency curriculum. Having repeated time in the simulation lab and during things like in situ sim really help train that muscle. We don't use that often, that stress muscle that in the emergency department we want to basically be gone by the end of residency. And I think building leadership into medical training is important. I mentioned before this idea of soft skills, communication, leadership skills, but really these are things that should be just as important to formally teach as all of our core didactic curriculum.
To piggyback off that, when do you think is an appropriate time to integrate a learner with some of these concepts that we've talked about? I think about it from my standpoint. At the end of my PGY 1 year, my first day of PGY 2 supervising an intern, my attending said, "Hey, you're going to be supervising this intern, and just make sure you do a good job of supervision and guiding them through this resuscitation." And I looked at my attending and I said, "Hey man, it's like my first day of second year. Like, what do you want me to do? How do you expect me to be a resuscitation leadership master over the course of 24 hours? I went from a PGY 1 to a PGY 2. But from your standpoint, when is a good time to start this integration process?
I think you make a great point. From one title to the next, from PGY 1 to 2, or from resident to attending, it's not like we magically become masters at our skills at resuscitation leadership. I think a really key point is that transition, like you mentioned, from junior resident to senior resident and that step up in roles. And this is just anecdotal, but I really do think the end of the PGY 1 year might be that golden moment where learners are primed to be prepared to learn these skills. Because really, you do need to master the core medical knowledge before you're really able to lead a team and think about communication skills in addition to medical management. But I think that's something that will be very program dependent because I think that change in leadership can really depend if you're a 3 year program, a 4 year program, or based on the institutional culture, depending on where you are.
Awesome. So let's say we start integrating our learners to a resuscitation leadership curriculum. What are some of the challenges that we can talk to them about early on, specifically with regards to common pitfalls like analysis paralysis or overleading, underleading? What are some of those challenges that we can keep an eye out for and just make sure we tackle them early on?
Yeah, it's really hard to step into this role of resuscitation leader. I think everybody is going to have different challenges. I think one of the things that you mentioned, over commanding versus under leading, there are going to be individuals who feel like they need to stand at the head of the bed and they may come off as not receptive to feedback if they're always basically barking orders at individuals. And it can be really hard when you're trying to raise your voice to get your voice heard in the room and to make sure that everything is going on track because you feel that pressure as a leader. On the other flip side of things, you're going to have people who really, really struggle specifically to get their voice heard, to feel comfortable saying, this is the medical management that I want to do. And it can be hard with imposter syndrome. It's something that a lot of trainees deal with, a lot of attendings deal with. Finding that right balance between over commanding and under leading, like you said, is something that takes a lot of time. And I think like we talked about earlier, utilizing your team and that shared mental model can really help with this because if you're continuously asking the room what they think, summarizing the case, you're really going to get that feedback from your team members and they're going to give you real-time feedback about your leadership as well.
That's actually a really great overview of some of the challenges that these young learners can really face with starting to develop these resuscitation leadership skills. So I think that was actually a great overview. Now, as we're getting ready and time is ticking down, Vicki, one of the questions that I ask all my guests is, if I'm a first-time listener, what are the 3 key big takeaways that I can take away from this episode?
The 3 main takeaways are one, that we should really have formalized training in these leadership skills. We're not born PGY 1 year ready to lead an entire resuscitation leadership team. And I think that formalized teaching is really essential and should be a part of every residency curriculum. I think the second important takeaway, some of those core skills that we talked about of being an effective resus leader, the closed loop communication, utilizing a shared mental model with your entire team, and importantly, that feeling of mutual support that you need to foster as the team leader so that it's a safe space and that everybody feels like they can contribute. And I think the third takeaway would be that simulation-based training is an awesome way to practice these skills. And it's really a safe environment where you can get great feedback from your simulation faculty and you can improve yourself so that when you're in a high stakes scenario, you feel ready.
Those are three incredible key takeaways. Number one being that formalized training. If we can integrate that into our medical curriculums, I think our learners can really benefit from that. Because again, this is something that you can't just expect your learner to develop. I mean, some folks might, but for a lot of folks out there, they can really do well with just getting some feedback on the development of these skills. And again, developing those skills and getting that real-time feedback from other instructors that have already mastered these skills, I think is really valuable. So specifically focusing on things like closed loop communication, the shared mental model that you talked about, and also trying to develop that mutual support from your team. And if we can try to integrate simulation-based training, I think that's only going to help our learners down the road as well. So I think those are three key big takeaways that you brought up, and I think they're really, really important for us to constantly reinforce. Final thoughts, Vicki, from your end regarding resuscitation leadership.
Just that it takes practice as everything in emergency medicine, and that really by the end of residency, if we integrate this in trainees' curriculum, I think they'll be ready no matter if it's a crazy tertiary care urban hospital or a critical access hospital. I think these skills really apply no matter where you practice.
Absolutely. I'm really glad that I was able to get you on to talk about this. Just for some of the guests, I heard Victoria's talk at the ASAP Teaching Fellowship, and it was phenomenal. And as soon as she got done, I thought to myself, I have to have her on. So this is like a dream come true. So I'm really happy that I was able to get you on to talk about resuscitation leadership, because again, there's not a lot of people out there that are talking about this. So I'm really happy that I was able to get you on and get your insight. So in our closing moments, Victoria, is there any place on social media that folks can reach out to you to talk to you about resuscitation leadership and get your guidance on maybe developing a curriculum around this or anything of that nature?
So I'm not super active on social media, but our residency program is at UVM residency, and I can always be reached out by email if needed.
I'll provide a link to the residency website. So for anybody that's interested, they can reach out to Vicki for any questions specifically that they might have. So resuscitation leadership is a vital thing that we can continue to develop into our medical education curriculum. But let's keep the conversation going. From your standpoint, let me know, what are you guys doing with resuscitation leadership? How are you developing your learners? How are you helping them develop these skills that can really help them as an attending physician? Let me know, and let's keep the conversation going. Thank you guys for tuning in. This was a fantastic episode. See you guys soon.